Hello everyone, my name is Samuel and I'll be taking you through renal pharmacology. Okay, so let's delve into it. This will be our outline. Okay, so the kidney are paired organs that are located on the posterior aspect of the abdomen, and the functional unit of the kidney is what the nephron. Performs major roles like filtration, filtration of blood plasma, regulation of fluid, electrolyte and acid-base balance. Then there is excretion of metabolic waste like urea and creatinine, and it also has endocrine functions like the production of erythropoietin, which is used in the production of red blood cells. There's the production of renin from certain cells of the nephron, which helps in the regulation of blood pressure from the renin-angiotensin-aldosterone system. Then there is vitamin D activation, so it helps in the production of activated vitamin D called calcitriol. Now, the nephron, like we said, is a functional unit of the kidney and it has certain parts. The parts is that it starts from what we call the glomerulus or from the renal corpuscle, then it continues down with the tubules and then it exits into the collecting duct. Okay, now the renal corpuscle is made up of the glomerulus and the renal capsule, also known as Bowman's capsule. The glomerulus is a duct of capillaries. Blood supply from the arteries would branch into arterioles. Eventually, that arterioles got afferent arteriole, and that would also branch into capillaries called or the glomerulus, and that is where ultrafiltration happens. That's where we filter out most of the macromolecules, okay, like proteins, albumin, and the rest. And then it continues down with the tubules. We have proximal convoluted tubule. That is a site where sodium chloride and then water, glucose, amino acids, most of them are absorbed. About 65 to 85% of them is the site of the action of carbonic anhydrase, for which we'll talk about soon. Then there is a loop of Henle, which is divided into descending and then the ascending. The descending limb is water permeable and solid impermeable, so it doesn't allow solutes to pass through. Then we have the thick ascending limb, which reabsorbs sodium, potassium, and chloride via this simple water. Then there is a distal convoluted tubule where reabsorption of sodium ions and chloride ions also occur via another symporter. So we'll be making use of a lot of symporters. Then eventually they will all end in what we call the collecting duct. The collecting duct contains two types of cells. We have the principal cells and the intercalated cells. And so that is where sodium reabsorption happens, potassium reabsorption, and then water reabsorption via ADH, that's the antidiuretic hormone sensitive aquaporins happen. So we'll look at it in details for the next presentations. So this is the kidney. The kidney is made up of the renal cortex, which is the outside. Then we have this pyramid, which makes up the renal medulla, and then there's the renal pelvis. Okay, the nephrons are located between the medulla and then the cortex. Mostly you have the proximal convoluted tubule, the glomerulus, and the distal convoluted tubule found in the cortex of the kidney. Then the descending and the ascending loop of Henle also found in what the medulla. Now, so this is what I meant by afferent arteriole branching into capillaries, and that form the glomerulus. It leaves via what we call the efferent arteriole, and this is surrounded by the Bowman's capsule or the renal capsule. Continues down with the proximal convoluted tubule, and remember we said the proximal convoluted tubule is the site where most reabsorptions occur, and this is the descending limb of the loop of Henle, and then we have the ascending limb, and this is the distal convoluted tubule as it connects it to the collecting duct. There are about 1 million nephrons in the human body and about thousands of collecting ducts. Okay, so that is one thing you have to take note of. Now, the next thing is that when you take the glomerular capsule, also known as the Bowman's capsule, there are two layers. We have the parietal layer and then the visceral layer. Remember we said ultrafiltration occurs in this place. Now the ultrafiltration is due to the filtration barrier, and the filtration barrier is made up of these cells, we have podocytes, and then we have the capillary endothelial cells, which are fenestrated, so there are pores or holes in between them. And then between the podocytes and the endothelial cells is what we call the basement membrane. Okay, so when blood from the capillaries gets here, some of the molecules escape, and then some of them, because of their small size, are able to pass through the basement membrane and then they leave. But some are stopped by the fenestrated endothelium. What it means is that red blood cells, which are very big, cannot pass through here. And then the basement membrane is negatively charged, and so some other macromolecules like proteins are stopped here, and so they are repelled because they are also negatively charged. Proteins cannot pass through the basement membrane. And then we have the podocyte. The podocyte has four processes. In between them, we have the diaphragm and then the slits. Okay, now the holes in between the processes, the podocyte also helps in filtering out some macromolecules. So some of the molecules which are very minute and small are able to pass through the processes and then continue down into the proximal convoluted tubule. Now the proximal convoluted tubule also contains some microvilli, that's the brush border cells. They tend to move to brush off some of the particles. But here it enhances the surface area of the cells, and that is in the absorption process. The proximal convoluted tubule, as you can see, is made up of very large amounts of mitochondria. Okay, then we have the infolding, and that's a basolateral aspect. That is where it faces the blood. Okay, so filtration here means that we are filtering out urine. Okay, we are filtering out urine, and then the urine will be filtered into the blood. That is the important aspect of the urine that the body needs are filtered into the blood, and that is the basolateral aspect. And the apical aspect is the lumen of the tubule. Okay, so those materials which are not filtered would be brushed off by the microvilli onto the descending limb of the loop of Henle or the nephron loop. Okay, so we have here too, we have some amount of filtrations happening, and then we move on to the thick ascending limb, and then to the distal convoluted tubule. Remember we said that distal convoluted tubule, just like that of the proximal convoluted tubule, also have an apical side and basolateral side. But unlike the proximal convoluted tubule, these ones do not have a lot of microvilli to sweep off the urine content. Okay. So let's move on and then we will know a bit more details about it. So the urine formation is that first there is filtration from the glomerulus, and then some reabsorption will happen in the proximal convoluted tubule, the loop of Henle, and then the distal convoluted tubule. Then there is secretions. What makes up the urine is that there are secretions. So some ions like hydrogen ion, the potassium ion, the ammonium ion are secreted into the urine to form part, and then finally it is what excreted. So there is filtration minus reabsorption. So reabsorption from the filtrate, and then what is left plus the secretion is what will eventually form urine, and then that is what is excreted. So what is the function of these agents called diuretics? Diuretics are drugs that increase the urine output by promoting what? The excretion of water and then electrolyte. Okay, and we have various types or categories of diuretics. What they do is they tend to cause a lot of urine to be what? Excreted. Diuresis means increased urination. Okay, so like I said, we have the afferent arteriole branching into the glomerulus, and we have some filtration happening here. Now, on the proximal convoluted tubule, we said majority of the reabsorption occurs here, and so we have agents that will tend to block the reabsorption process here, and these ones we have those ones called carbonic anhydrase inhibitors. there is an enzyme called carbonic anhydrase. We'll talk about it. We have acetazolamide as one of them, and even some of the osmotic diuretics like mannitol would also act here. Okay. Then the descending limb of the loop of Henle to is permeable to water. So we want to get some diuretics that would increase water excretion here, and that the ones that act in this here is the osmotic diuretics too. They can have effect here. Okay, then we have ascending limb. The ascending limb has a channel called the sodium potassium chloride channel that helps in the reabsorption of sodium, potassium, and the chloride. And here the the drugs or the agents that act here are what, the loop diuretics. Okay, then we have others called thiazide diuretics acting on the distal convoluted tubule, and then we have those that will act on the collecting duct itself. So let's move on. Carbonic anhydrase inhibitors examples. The main examples we have are the acetazolamide, which is the main systemic agent that is mostly used. There is what we call dozalamide and benzolamide. They are topically used for the management of glaucoma. So the mechanism of action is that they tend to act on the what, proximal convoluted tubule, and they inhibit an enzyme called carbonic anhydrase. So this is the what I mean by they inhibiting an enzyme called carbonic anhydrase. So the enzyme carbonic anhydrase has two things that it does. What it does is that it helps in the conversion of what, carbon dioxide and water into carbonic acid, and then also breaking down the carbonic acid into what, H plus ion and bicarbonate ions. All right, so that these ones would tend to, so as you can see from here, the carbon dioxide and water can enter into the from the urine into the cells, and in the cells this same carbonic anhydrase will convert it into bicarbonate, and then we have what, H plus ion and HCO3 minus ions being produced, and these ones, the bicarbonate ions can also leave via a transporter here. Okay, now one thing that we want to take note about diuretics is that mostly whenever we are talking about a particular tubule, we would talk about the basolateral membrane, and then we talk about the apical membrane. The basolateral membrane is the one that is close to the blood, so that is where the filtered solutes would what, go to. Okay, and those unfiltered ones will be part of the apical membrane or the urine. Okay, as the basolateral aspect of the proximal convoluted tubule and all other tubules contain a sodium potassium ATPase, and that is what is going to create the gradient for the transport of these molecules. Okay, so for a particular molecule to be absorbed or filtered, we need the action of the sodium potassium ATPase to create the gradient. What it does is that it pumps 3 sodium ions out and then 2 potassium ions inside. Okay, depending on the needs of what, the cell. Okay, so acetazolamide, which is a carbonic anhydrase inhibitor, tends to inhibit that enzyme, which will convert the carbon dioxide in the water into carbonic acid. So eventually, what that happens, it means that all the water and the carbon dioxide will what, would be part of what, the urine, and so they will be what, removed via urination. Okay, we also have some agents there, and the proximal convoluted tubule. There is a sodium glucose channel, and SGL2 inhibitors, which is used in the management of diabetes, will tend to act here. All right. So what I said was that there is decreased H plus secretion and then decreased sodium ion what, reabsorption, and they tend to decrease bicarbonate reabsorption and then increase bicarbonate what, excretion. That is what it all means, whatever I explained. And so what you tend to do is, if you have a lot of bicarbonate, and means it makes the urine alkaline or basic. Okay, and that would eventually lead to what we call what, metabolic acidosis, meaning we will have a buildup of what, H plus ions in the blood. Okay, then the clinical uses, like we said, that is used in glaucoma to decrease the aqueous humor production. Remember, it's a diuretic, so wherever fluid is built up, you want to draw that fluid and then pull it away. Do you understand? So in aqueous humor, in glaucoma, there's an increased amount of aqueous humor, and that is going to what decrease the amount of aqueous humor. Metabolic alkalosis, you can use it because it causes metabolic acidosis. Okay, in altitude sickness, which is also known as the mountain sickness, it's very important that you keep this because mostly it comes in the exams. What happens here is that as you go higher, you climb up to the mountains, the partial pressure of carbon dioxide what decreases. Why? Because the oxygen, you gas more for oxygen because the oxygen content high up is what very low. So you try to breathe in. That's hyperventilation. Breathe in very very fast. When you are doing that, you don't have time to excrete the carbon dioxide out. So the carbon dioxide there would tend to build up. Okay, now when that happens, um, as a way of compensation, your um, you go into what we call a respiratory alkalosis. Okay, you go into a respiratory alkalosis, and what happens is that the when you give a carbonic anhydrase, because it's going to cause excretion of what bicarbonate ions. Okay, this is going to decrease the amount of what carbon dioxide. So the excretion of the carbon dioxide, which was supposed to be done by the lungs into the outside, will now be done by the kidneys and then will be removed eventually. Okay, so that's how we use as a prophylaxis for mountain sickness. Then is used in adjuvant as an adjuvant in epilepsy management and then periodic paralysis. The adverse effects is that because they tend to decrease the levels of bicarbonate, they cause high metabolic acidosis. And remember that there is also increased excretion of what potassium ions. Remember, potassium ions are moving, and so we'll be excreting a lot of potassium ions too as well. That will cause hypokalemia, and this would have CNS effects and will cause tingling sensations or paresthesia. This is something that is high you want to keep in your mind. And there is also the formation of what kidney stones. Because the urine is alkaline, it tends to favor precipitation, and that will build up stones and will block the urethra and the other channels through which urine will pass through. Then they also have tend to have allergy. They cause some allergies because they contain sulfur. They cause hypersensitivity. Okay, invert acetazolamide is used in the same way glaucoma in dogs and cats. It will cause hyperkalemia, periodic paralysis in horses. You want to use that. Respiratory alkalosis at high altitudes in performance animals too, we can use acetazolamide. Okay, but then there is risk of acid base imbalance in that there is going to be causation of what metabolic acidosis. Okay, so that's one thing you have to take note of. Now let's move on to osmotic diuretics. Osmotic diuretics example is mannitol, which is the main agent. There is also urea and glycerol, which is also used in the management of glaucoma. The site of action is that they act throughout the nephron. Remember, I mentioned the proximal convoluted tubule, and I also mentioned the loop of Henle. Okay, these ones are freely filtered at the glomerulus, but we do not reabsorb the mannitol and the urea and glycerol. And so what they do is that they tend to create what we call an osmotic gradient in the lumen, and that is going to inhibit passive reabsorption of water. So they tend to like in a way bind to the water molecules to attract them to a cell, and some ions like sodium and potassium do as well. So when that happens, you tend to have water in the built up in the urine lumen and forms part of the urine is excreted out. Clinically, we use it in the management of acute cerebral edema when there is what decrease in intracranial pressure. It decreases the intracranial pressure. In glaucoma too, it decreases the intraocular pressure. Then in people with acute renal failure, where people with kidney failures, most of them would come with pedal pitting edema, and we want to also use these ones to maintain the urine output in the early stages and to eliminate some toxins to enhance renal excretion. The adverse effect is that they tend to cause volume expansion. So people with congestive heart failure, remember they have pulmonary edema. Now, what happens is that when we are giving these agents, they tend to, you see, they tend to decrease the amount of water that is being reabsorbed. Okay, but that is not only the case. They don't only act on the kidneys; they can act on other sides of the body too as well. All right. So what happens is that they tend to collect the water into the extracellular space. So it's going to, in a way, like worsen the edema process in pulmonary edema. And remember, we said that they tend to reabsorb, they tend to inhibit the passive absorption of sodium ion, so they cause hyponatremia initially, then later there is hypernatremia, and that's what is leading to electrolyte imbalances. Some people can also come with CNS symptoms like headache, nausea, and vomiting. The contraindication is that if a person has pulmonary edema, you don't want to give it because it's going to worsen it. If a person has severe dehydration, because the diuresis is going to drain water from the person, you don't need to give these agents. If a person is having an intracranial bleeding, that is going to also worsen the bleeding process. You don't need to give it unless maybe you have planned to remove that portion of the brain. Mannitol is also explored in vet, that is in dogs and cats. We use it in the management of cerebral edema, acute glaucoma, and then acute kidney injury to maintain perfusion. You give it IV and then you closely monitor it. Okay. Then the next part we will talk about are the loop diuretics. The loop diuretics are furosemide, bometanide, torsemide, and itacranic acid. The most agent that is used in our setting is furosemide and is the most common use. Okay, all these agents contain sulfur with the exception of itacranic acid. Okay, so if you have someone who has sulfur allergy, you don't want to give furosemide or any of these agents, but you can give itacranic acid. So let's talk about the mechanism of action. They act in the thick assembling limb of the loop of Henle, like I mentioned. And what they do is that they tend to inhibit sodium, potassium, chloride, iron, and sympathia. Okay, so what happens is that there is decreased sodium, decreased chloride, decreased potassium reabsorption, and decreased medullary osmotic gradient. Wherever sodium goes, water goes. So decreased water reabsorption. Eventually, that's going to lead to increased urine output. Okay. Some of the additional effects for loop diuretics that you want to remember is that they tend to increase the calcium and magnesium ion excretion, unlike other thiazides. Okay, and another thing is that they stimulate the action of PGE2, which is a prostaglandin that will tend to cause vasodilation of the renal efferent arteriole, and that um, there is also increased renin release, and that is due to volume depletion. So clinically, we use it in pulmonary edema, acute pulmonary edema, congestive heart failure, very safe to use, unlike the other ones we talked about, like the osmotic diuretics. We have severe hypertension. You want to give it hypercalcemia and then hyperkalemia because they can cause hypokalemia. Okay. Now, the adverse effect is remembered by ODAN, which is ototoxicity, especially with itacranic acid. They tend to be harmful to the ear. There is hypokalemia. Remember we said that decreased levels of potassium, hypomagnesia, because we excrete a lot of magnesium, and then because it's a diuretic, eventually it's going to cause dehydration. Some of them causes allergy, sulfur allergy, with the exception of the itacranic acid. Then metabolic alkalosis. Why? Because we tend to be excreting a lot of H plus ions, and that is going to cause build up of bicarbonate ions that will lead to the alkalosis process. And then nephritis, okay, interstitial nephritis. There's also hypocalcemia. Remember, we talk about the calcium ions. And there's hyperuricemia, and that is going to eventually lead to what we call gout. Okay, so this is ODAN. Take note of it. In vet, we use loop diuretics in canine and feline congestive heart failure. We administer them IV or oral in pulmonary edema. Furosemide is the one that is widely used for edema. You have to monitor the electrolytes and the hydration levels when you put a patient on furosemide for a very long time. Okay, these loop diuretics are known as high ceiling diuretics. Why? Because they are the most potent diuretics. They tend to cause the most diuresis. Okay, so they are high ceiling. They tend to cause the most diuresis, the most effect, the most enhanced effect. Take note of it. Okay, so what I mentioned is that there is the sodium potassium chloride symporter that tend to reabsorption of sodium, potassium, and chloride ions. Loop diuretics will go and inhibit this, and when that happens, all the sodium, potassium, and the chloride will form part of what the urine, and then they are excreted. There is also potassium levels here which are also escaping. Now remember I said that in every part of the tubule you should be expecting what sodium potassium ATPase. That is what is going to cause what the creation of the gradient to cause either sodium efflux or the other ions. Okay, so you can see that we have 3 sodium ions leaving into the blood and then 2 potassium ions going into the cell. That will create the gradient for the sodium ions to move in, potassium ions to move in, chloride ions to also move in. Okay, now once this is inhibited, you will see that the effect is going to be what greatly enhanced. Now the magnesium and then the calcium ions can also be reabsorbed pancellularly between two cellular cells into the bloodstream. Okay, now once loop diuretics are working, they tend to also have effect on the reabsorption of these to the magnesium ion, the calcium ion. So they also don't move and they are excreted as part of what the urine. Okay. Now the next type of diuretics we talk about are the thiazide diuretics, which tend to act on the distal convoluted tubule. Okay, the examples, the main prototype is hydrochlorothiazide and then chlorothiazide. These ones are the true thiazide diuretics, hydrochlorothiazide and then chlorothiazide. The thiazide-like diuretics are clothalidone, indapamide, and then metolazone. These ones are thiazide-like. Okay, remember the site of action is what the distal convoluted tubule. The mechanism is that they inhibit what we call the sodium chloride symporter, which when that happens, it means that there is going to what decrease levels of sodium, decrease levels of what chloride, and that is going to cause what more diuresis. Okay, the additional effect is that they also tend to cause increased calcium reabsorption, unlike the loop diuretics that we mentioned, and so they are beneficial in the management of osteoporosis and calcium nephrolithiasis. Okay, why? Because they tend to also cause increased levels of glucose, uric acid, and what lipids. Okay, with chronic use. The clinical uses is that they are used in the management of hypertension. We can also use them in what mild to moderate congestive heart failure. People with nephrogenic diabetes insipidus, you want to give thiazide or diuretics. Calcium containing kidney stones, to decrease the urinary calcium ions, you want to also give what thiazide diuretics because what they tend to cause increase in what calcium reabsorption. The adverse effect is that because they tend to cause hypokalemia, metabolic alkalosis, hyponatremia, that's low sodium ions, and then they have effects on the glucose levels. They tend to increase glucose, uric acid, and lipids. So you will see that there's what we call hypergluc. Okay, hypergluc. So hyper for glycemia, hyperlipidemia, hyperuricemia, hypercalcemia. Okay, so that's what hypergluc. That's how you remember it. Then they are all sulfur containing drugs, so they tend to cause what sulfur allergy. In fact, they are used for canine hypertension and refractory edema. Sometimes we combine them with what loop diuretics like metolazone with furosemide, okay, in very resistant cases. And remember, whenever you are giving diuretics, you need to what monitor your electrolyte. So what I meant was that the thiazide diuretics, when they act on the distal convoluted tubule, they tend to block this ion channel, which is like the symporter for sodium and yeah, so there's chloride ions moving, sodium also moving, and they are reabsorbed. Thiazide diuretics tend to inhibit this action. And there also you can see that there's magnesium and then calcium ions moving in. This tends to promote the action of what the movement of calcium into the interstitium or the blood. Okay, here too, another agent like the remember I said that the parathyroid hormone tend to also act toward increase the reabsorption here in the initial presentation. So it binds to its receptors and then tend to cause calcium and iron reabsorption. Okay, so let's move on. The next one is the potassium sporin diuretics. These are diuretics that are mainly used to prevent what potassium ion loss when you combine them with what other diuretics. Okay, now the subclasses, we have two types of them. We have aldosterone antagonists and then we have the ENaC blockers. That's epithelial sodium channels in the collecting duct blockers. Okay, now the aldosterone antagonists are spironolactone and then eplerenone, and then we have amiloride and then triamcinolone as what ENaC blockers. So how do they act? Their action is that for the um, aldosterone antagonists, they tend to block aldosterone receptors in the collecting duct. Okay, so remember that I mentioned that your collecting duct, the collecting duct has two types of cells. We have the principal cells and the intercalated cells. The intercalated cells are also divided into two: alpha intercalated and then what beta intercalated cells. Okay, now the principal cells contain certain receptors for aldosterone. Okay, as well as some of the alpha intercalated cell, and aldosterone tend to bind to these receptors. Remember that when aldosterone bind to these receptors, it tends to increase sodium reabsorption, and that is also going to lead to what water retention, which would eventually lead to what increased blood volume and what pressure. Also, it tends to increase the potassium and what H plus ions what excretion, so it helps in maintaining electrolyte and acid base balance too as well. Okay, and this is achieved by what acting on the ENaC cells and that of what the sodium potassium ATPase. So as you can see here, that is what the aldosterones. Okay, once that happens, there is what increased excretion, reabsorption of what sodium. Okay, now we give agents like spironolactone and eplerenone that is going to what inhibit the action of what aldosterone. Okay, then the epithelial sodium channels to when you give amiloride and triamterene, that will also block to inhibit them so that sodium reabsorption will be decreased, and so we have a lot of sodium excreted. More sodium excreting means that we will have a lot of what water to being what excreted. Now you see that when aldosterone binds to the V2 receptors, they tend to increase the aquaporin levels on the membranes, and increased aquaporins would tend to enhance water reabsorption. And so once we are blocking that, it means that water would be what built up in the urine. So wherever sodium moves, water also moves. Okay, so that is it. And to remember these drugs, like I said, you need to keep your seat. Okay, keep your seat. The seat here is spironolactone, eplerenone, amiloride, and then triamterene. K from keep forward, potassium sporin drugs. Okay, then the clinical use is that for the aldosterone antagonists, they are used in congestive heart failure. They are not used alone; they are used with other agents. So we have hyperaldosteronism, aldosteronism, whether it's primary or secondary, you need to give potassium sporin drug. Then people with liver cirrhosis who come with ascites as well, we can give these agents. And people with polycystic ovarian syndrome, we give spironolactone. And resistant hypertension to sometimes we explore the use of what potassium sparing diuretics. Inner blockers are used in the management of Liddle syndrome, and there's lithium induced nephrogenic diabetes insipidus, and then we have what mild hypertension. The adverse effects is that because we are um there is decreased potassium secretion is going to cause hyperkalemia, and then metabolic acidosis because of what the decreased levels of what H plus ion being what secreted. Okay, and spironolactone specifically can cause gynecomastia. This is something you want to remember in the exams. Okay, which agent causes gynecomastia? That's spironolactone. Okay, and then sometimes it can lead to impotence with frequent use, and then it can cause menstrual irregularities too as well. Okay, so in summary, the diuretics are grouped into loop diuretics, thiazide diuretics, potassium sparing diuretics, carbonic anhydrase inhibitors, and osmotic diuretics. Loop diuretics are furosemide, that's the prototype. They tend to act on the sodium potassium chloride transporters, and so the toxicity is remembered by PODAN. There's thiazide diuretics which act on the distal convoluted tubule. They inhibit the sodium chloride ions co-transporter. The main agent is hydrochlorothiazide, and then we have the thiazide-like diuretics like the clothalidone. They tend to cause hypokalemia, hyperuricemia, hyperglycemia. So we say hyper gluc. And then we have the potassium sparing diuretics which act on the collecting that. And then we said there are two types. We have the aldosterone antagonists which decrease sodium reabsorption, and those ones are spironolactone and eplerenone. And there is the inner blockers which tend to decrease sodium reabsorption too as well. And those ones are amiloride and triamterene. Okay, they all cause hyperkalemia, but spironolactone causes gynecomastia. Okay, then we have carbonic anhydrase inhibitors. They tend to act on the proximal convoluted tubule, and the prototype is acetazolamide. They inhibit carbonic anhydrase, decrease sodium and bicarbonate reabsorption, which will eventually lead to metabolic acidosis, hypokalemia, and the buildup of stones. And CNS would respond by tingling sensations called paresthesia. And then we have the osmotic diuretics, which tend to act on the proximal convoluted tubule and the loop of Henle. And the prototype is mannitol. We can also have urea and glycerol used in the management of glaucoma. They tend to increase tubular fluid osmolarity that will decrease water reabsorption, and that is used in the side effect is that it causes pulmonary edema, dehydration, and then electrolyte imbalance. Thank you.